Yeah, morning, Dr. Y.V.C. Reddy and Dr. Elilan. Good morning and respects to the chair. Thanks for having us and gratitude to the organizers for giving us the opportunity. So we are here live from MGM Hospital, Chennai. We have a full team here. To my right is Dr. Abu. We have Dr. Vivegan in the back, and we have Dr. Swapna and Dr. Smirna from anesthetic side. So I'll proceed with the case history first. Give me a second while we're just in the process of doing the first part of the bifurcation. I just want to make sure patient is okay. Okay, now we'll talk. So this is a gentleman who's 65 years old. He is a patient who's got liver disease and is due for liver transplantation at another center. He's had previous hepatocellular carcinoma. He had a partial lobectomy of the liver in 2015 and had radiotherapy then. Now there has been some spread, and the plan is to do liver transplantation. His liver parameters are distorted. However, his coagulation is not too bad. INR was normal. His prothrombin time is 17. His hemoglobin, although he's had only one upper GI bleed, it's now 10. So now things were stable. Renal function is normal. As part of his liver transplantation workup, he was discovered to have severe coronary artery disease, and he was deemed high risk for open heart surgery given his liver disease. So he was referred to our center for percutaneous correction to allow him have a liver transplantation. He didn't have much in the way of symptoms, but because there's significant coronary artery disease, when you probe him, he probably has angina 1 to 2, class 1 to 2. So it's not severe, but given his liver transplantation, as we know, there's going to be a huge fluid shift. It's logical to revascularize to allow him to have a safe liver transplantation. So before we embark, clearly our plan is to look at the coronaries, use a dual antiplatelet regime with no more than 4 to 6 weeks. Therefore, the stents we're going to opt for is Onyx. We're going to do OCT guided to make sure that the procedural outcome is as favorable as we would like, to allow quick endothelialization and allow him come off dual antiplatelet to have a safe liver transplant. So all these endpoints are being borne in mind before we start this case. So I will play the index angiogram which was done in the parent center. Can we play that angiogram, please? You're okay, Swapna? So let's play the angiogram. Can you see the angiogram there? Okay, so he has a inferior wall motion abnormality on echocardiogram, but his overall LVEF is 55%. More importantly, the anterior and lateral wall are completely viable and they're contracting and they were normal. So this is a small right, which as you can see feeds an AV circumflex, which is occluded. Next. This is the left coronary artery. You would agree that there is disease extending from the distal left main into the LAD, and the OM has a disease. One couldn't be sure whether that is a bend or a true narrowing. Next. Next. Here I think you can appreciate severe calcific disease of the LAD, severe stenosis of the proximal, and the distal vessel is pretty good. So I thought he will need treatment from left main all the way up till the last septal or diagonal, whatever you call that. Next. Okay, that should do. Can we switch to today's angiogram, please? So the plan was here to, of course, we're going to ignore the right. We have no plans to do anything to the right. We want to restudy the left system with a guide system, do an OCT of the circumflex to see if that needs treatment, and then do whatever is required. So let's switch on to today's angiogram. So this is today's angiogram with a 6 French guide from the right radial artery approach. And here you can see, appreciate better the amount of calcification. Next. Again, we couldn't be sure. There is clearly some moderate atheroma in the proximal OM, but that mid OM, I couldn't be sure whether it's a narrowing or a bend. but you can appreciate the proximal calcification of from the ostial LAD up to the mid LAD. Next. Next. This view, probably one can appreciate the amount of very thick calcium and the very critical narrowing in the proximal LAD there. You can see and calcification extending up to the mid vessel. Next. Okay, so here the plan was to first study the circumflex to know what we need to do, so that whether we can afford to do a provisional, because I want to minimize stents given the liver transplantation. You don't want any TLRs. If you can afford to do a provisional, fine, well and good. Otherwise, we'll have to do a 2-stent strategy from the outset. So we plan to study the circumflex. Next. 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 So we wired the circumflex. This is a Whisper MS, and we did an OCT of the circumflex. Can we show the OCT of the circumflex, please? Can we show the OCT? Switch to OCT, please.
Gopal, we are not seeing the image in a bigger way. Is there a big OM branch and circumflex is occluded after the Ramus-type OM?
No, there is an AV circumflex that is occluded, which fills retrograde from the right injection, which you saw. So that is something.
The left injection, the big one was filling.
Let's show. That's the same that you're seeing. Ipsilateral collateral. Yes, yes.
Yeah.
That's the
So
same.
we are now
Yeah.
we're not going to touch that.
No, we have no intentions to touch that at all. We are just going to fix the OM, if at all needed, based on the OCT. Can you see the image as well? Shall we mag up on the images?
I think so. Yeah.
Okay, let's come off everything and just give us the images. Make the image big. Make the angio big, please. Can you see the angios better now? Okay, can we show the OCT now? Just OCT alone, we don't need angio. No picture in picture. Can you
just focus on the picture now?
Okay, can you see the OCT?
Yeah.
Okay, so the OCT you can see here, and this is the distal. Just come forward, please. There. You saw the distal disease there. It was quite significant narrowing rather than a true bend there. That is the distal disease. Let's come to the proximal vessel. So the more important thing is the proximal vessel, which is what is going to decide whether we need a 2-stent strategy or upfront bifurcation strategy. So this is just at the ostium. Just show us demonstrate the left main also to say that we are indeed at the ostium there. That is the bifurcation. Go back into the circumflex ostium. There. So that is quite significant. Luminal area is 1.45, and given that he has no other vessel to the lateral wall, I thought we should embark on treating this entire vessel, which means a 2-stent strategy right from the outset. So to start with, we have stented the mid. Next one. Next angio, please. Yes. Next angio. Angio. Next. So we just pre-dilated that, and we put an Onyx 2.75 stent there, the mid vessel. Post dilate. Next. 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 Okay. So come back there. Okay, stop. So you can see the angio. We have treated the circumflex. Now I didn't want to put the proximal stent. I want to stabilize the LAD because if we were to do kissing balloons with no flow in the LAD with severe disease, we don't want to end up in a situation where we can't deliver the kit to the proximal or the mid LAD. So I switched my attention now to the LAD intentionally without treating the proximal vessel to come back again. Next. So the LAD, as you can see, has severe calcification. I tried to get an OCT, but I thought I was greedy. It didn't go through as expected, so we didn't touch that. Then we took a balloon, a soft balloon. Next, next, next. You can see there's significant indentation there. So show there. There you can see the indentation. The calcium wouldn't allow dilatation, so we decided to modify this this disease with lithotripsy. Next, so we used a 2.5 by 12 lithotripsy. There. Next. So there was a lot of indentation. We delivered all the 10 cycles from the left main into the mid LAD. Next. Then I took a 3 balloon to try and open it to be absolutely sure we don't need to upsize the lithotripsy to a 3. This is a 3. Next. Show the 3 balloon, please. This is a 3 balloon, so I was reasonably convinced that we have modified the plaque there. Next. Now we did an OCT of the LAD. Can we show the OCT of the LAD, please? This was just to know the size of the LAD so that we know the LAD and the left main to know what size stent we take. So you can see a few cracks here and there. And a dissection plane there. So there you saw the left main's 4 millimeter vessel. So that's where we are now. So now what we are in the process of doing is go back to the angio, please, is to now stent the proximal left circumflex, crush it with a 3-5 balloon from the LAD, and then stent the LAD. Essentially, the strategy will be a DK crush of the left main bifurcation. That is the plan. Please give your inputs and thoughts if I may have missed anything.
Really challenging HPR scenario case, Gopal.
Yeah.
And you are forced to go with a 2-stent strategy. As you rightly said, you would like to initially choose, if possible, a non-DAP dependent strategy, but of course here you had to use a 2-stent and you have done the initial circumflex preparation well. Now, I think as you rightly have shown, without an IVL,
What's this?
could have been tough to prepare. You have produced
Balloon in the LAD.
section planes, but definitely there was calcium cracks as well.
Yes.
So you have done the job with IVL, and now DK crush is the right way forward here. I think you are on the right track. I think we'll be interested to see how you proceed with these
Yes.
other steps.
So other
Very nice thing. Ellen, your inputs.
Yeah,
Even if you are there.
yeah, the
Stent
circumflex,
next.
I think imaging really helped. We didn't know that the distal circumference lesion was it really tight, but OCT clearly showed us that that also has to be removed. And so, having centered the distal
Stent.
mid circ, and then now coming to deal with the bifurcation of the right side. Imaging helps to take the right decision.
So what I've done now is I have just parked a, prepare this balloon please. I have just parked, prepare this balloon please. I have parked a 3-5 balloon in the LAD distally. This is to allow me do a kiss and crush of the circumflex stent. I am now taking a 3 by 15 stent onyx into the circumflex. So we're going to overlap from the mid onyx that you saw there. Where overlap பண்ண பாத்துங்க. Put some gauze there. Secure this wire. Wire. So we're getting a stent going in. Again, the circumflex stent is just being introduced as we speak. Be prepared to load the stent. Okay, cone down, super mag, and give me a bifurcational view. Stent boost on.
It would be interesting to see whether Gopal decides on a micro crush or a mini crush.
You put me on pressure now. I'm going to go for the safest approach here because we don't want to miss the landing zone and leave a bare area.
Sometimes you place for a mini crush,
Yeah.
and then the stent foreshortening will make it a micro crush.
Absolutely, and many a times I think I will achieve something, but very often I'm wrong. But what I achieve is completely different, and then I just have to act as though that's what I aimed for.
Intention to treat.
So it looks okay there. What do you think, panelists? There, it's probably too much here.
Some other angle. See, this is too much budget.
Yeah,
You
too
put
much.
deep
Just give us
underworld
some more,
model and
please.
something.
Just go to spider. Go to spider, guys. Everything connected? So I'm just going to come back a bit. I'm not comfortable here. There. That looks okay there. What do you think?
Yeah. Yes. This is.
Okay, we're just going to check another view too. Come back on AP caudal, please. AP caudal. Okay, that looks okay there. Okay, up on the stent, please, Abu.
Six, 8, 10, 12,
12, 12, 14, 16. Okay, the stent is expanded well. We prepared it okay. Okay, down. Okay, go up on the stent again. Up.
12,
12, 14, 16, 18.
18.
Okay, down. Okay, go up on the stent. 12, 14, 16, 18.
16, 18.
Okay, down.
This was a very important step. The last one.
Yeah. So I was just optimizing the proximal end, and let's get rid of everything from here, please. Abu, get rid of everything. Okay, I need the wire again. Okay, up on the LED, please. Abu,
12, 14,
nice. 14, 16, 18,
18,
20,
20.
down. Okay, go up there. 18, 20.
18, 16, 18, 20.
Take another wire. Whisper MS, please. Down. Down.
Lay down, sir.
Okay. The guide was clearly going in with the balloon, so I know nothing is sticking out. I'm comfortable. We have enough space there to be able to get kit down the LED side. Any thoughts, inputs from the expert panel there? I'm just going to.
Ramchandra, you can chip in, please.
Yeah, I'm just going to wire the circumflex now, and then we will treat the LED, and then we will open the stent struts perhaps
Gopal, it's
towards the end.
interesting because I've seen some operators. I will do that. I will follow just like what you're doing. They will put the LED balloon way down distally when they are putting the side branch stent.
Yeah.
I'm always scared it might get caught. Do you ever do that?
Sorry, I didn't get that. Sorry, come back
The
again.
LED balloon,
Uh-huh.
when the side branch stent was being deployed, was just right at the spot. That is what the classical teaching is. But I've seen some operators pushing the LED balloon distally
Yeah.
when the side branch stent is deployed.
I don't.
Have you ever done that? I have
No,
not done that.
I don't.
Yeah,
Don't.
it's a very risky step. I don't know why.
I'm scared.
Yes.
I have seen instances where they are not able to pull back the balloon.
Yes. Yes.
Has happened.
Wire, please.
any run-of-the-mill wire would be okay in expert hands, but for beginners, would you like to recommend any special wire for this?
I think
type of entry now?
I think any wire, as you say, any wire, whatever you're comfortable with and whatever rotates with you, and it should. I've never had a problem. But Whisper MS is sort of my workhorse for all this, because I would get some medium support of the shaft too, because we can track balloons and everything, and it's fairly safe. Okay. May I talk, please? Cone down, super mag, all the way. Just need to see the stent. Boys, come. So the intention is to cross somewhere sort of mid, so we'll see where we end up. It's somewhere in the mid, but some resistance. Let's see.
I will say, would you confirm with the OCT crossing, or you will accept?
I usually won't be worried too much about that.
Yeah. Yeah. So, yeah.
Because fluoroscopically itself, I think we will know whether it is a proximal or mid. Distal most we will avoid anyway, because of fear of carinal subintimal substent, extra stent passage. I think this would be, this won't need, I personally won't believe that we should do an OCT to confirm that.
Okay. Get a balloon, please.
You do that,
3 balloon.
Alan?
No.
You also do.
Yeah.
Most of the patients are sick and we cannot afford to.
3 new balloon.
give extra dye.
Get a new balloon. New balloon and stents. Get a 275 by 24.
So if you compare this with Pilar, that here, the main vessel wire is always there.
3 litho balloons.
Very confidently you can carry out the case.
So we have crossed the circumflex stent. As you saw, angiographically, I was convinced I was not distal. I mean, that's my only aim. As long as I'm mid or it's okay, you could confirm with OCT, but as you say, I never do that. I just go roughly on fluoroscopy, just to minimize the steps, contrast load, and complexity of the procedure. Now we are just going to open the stent struts, and then we're going to we're just going to stent the LAD first. LAD 275 24, please.
275 24.
Are we running late in terms of time? 275 22 is fine. 22 போட்டு அப்புறம் 3 போட்டுக்கலாம். After that we'll take a 3 stent. We are just keeping a wire here, but we will have to once we stent completely, we'll get a wire. We'll have to recross again. This is just for safety, because the patient has no other vessel for the lateral wall. So this is just more for safety. We'll just dilate and then we'll redo. One can argue that you don't need to dilate. Why don't you just stent across the LAD left main and then recross and then dilate? But this is just to make sure there's absolutely no way that we cannot get anything due to stent material in the jail.
Gopal, actually, the last case was did from Calicut. They did a classic micro crush. So as you said, if in this step of initial balloon kissing, balloon crush, if you don't want to do, you could straight away go like what the case was shown before.
Okay.
That was a straight away 2 stent simultaneous micro crush.
This was we have actually taken a 6 French guide, so we just going to do a stent and a balloon kind of thing.
This is always more safer in the sense recrossability will never be in doubt.
Correct.
The chances will be of unsuccessful kissing final inflation is very less with this.
I think in emergencies, I would probably take sort of semi-emergencies, reasonable to take, but for electives, it's best to take the one step at a stage. Cranial, please.
And again, as Gopal's point is very right, if it is a 6 French and you are dealing with this two-stent strategy in the left main, you 6 French won't allow. But if it is a
Small
diagonal
test.
LAD like the previous case they showed, yes, you could go with two
Small
stents in
test.
6 French as well. At the proximal left main areas, 2 stents simultaneously, you don't, 6 will not be enough.
Okay, we have a wire problem. Talker, please. Sorry, I'm just having an embarrassing step in a live case, so bear with me. That should do. Irrigation. Small test. Prepare the stent, please. Prepare the stent. Okay, go up. 2, 4,
Yes, sir. 2, 3, 4,
6, 8,
6, 8, 10, 12,
12.
12 nominal,
14.
14.
Okay, down.
The HPR and the DAP-dependent two-stent strategy, one has to get a good result. I think imaging is very important. That
Okay, go up.
results for optimal result, so that we can
13,
shorten
14,
the
14,
DAP region.
16,
And the stents chosen also, like the Onyx, which has enough data to show that short DAP is okay for the stent.
Absolutely. So, okay, down. Okay, go up. 18,
6 to 18, sir.
18. Okay, down. So we're just gonna do a sizing shot with this, just to decide what size we need. Okay, go up there. So this is a 22.
I'm at 18, sir.
Okay, 18,
18, sir.
20,
20.
down. So the calcium bulk is quite a lot. You can see the expansion is all on the opposite side, but at least we have some expansion. Go up, Babu.
20, sir.
20.
20.
Okay, down. So with the sizing shot, what would you recommend in terms of size we choose? That is a sizing shot with a 22 stent. We want to cover the left main. So a 30, 32 or 34. We don't mind an overlap distally. There's a little bit of there's one 34.
Yeah, 34 should go.
Okay.
The overlap distally is very minimal.
I think we'll take a 34, please. 334. ACT ஒன்று பண்ணிருங்க. Just check an ACT for us. And before we put the stent, this wire out and recross.
34. இது 22.
22.
Overlap பொறுத்து
ஆமா. 2 millimeter here. 22. 28.
standard
32.
aorta வரைக்கும் உள்ள வரைக்கும்
We need to come up with the left main.
left main ostium வரைக்கும்
Left main ostium.
334.
Yeah. 34 will, I think,
The 34 will be too long.
32.
No, is that dilating the ostium?
I don't want to cover the ostium of the left main because that looked normal, sir, on the OCT.
Then, okay. Then if you're not catching the ostium, then I think 32 also.
32.
Gopal, with that much of work being done,
You think?
what is the hesitation in covering up the ostium
Uh,
without any projection? Or without projecting into the aorta, if you can do probably a lower rim cover.
Sure. I mean, we're not, that still is not going to, okay, you just want to go up till at least one rim. So we'll put a 34. It's just that we're going to have a lot of overlap distally, and you can see one septal or diagonal has actually started to give slow flow. I'm just worried about the double layer.
Do one OCT run for the exact length if you want to avoid all that is okay. Otherwise,
I think 34 is fine. 34 is good. 34 will dilate a bit more. 34, 3 by 34. 3 by 34, the intention is to put a 3 by 34 and pot with a short 4 balloon because the size of the left main was 4. 4 by 6, please.
4 6 எடுத்து வச்சுக்கோங்க இது கொடுத்துறோம்
4 by 12 எடுத்தாலும் பரவாயில்ல. We're going to get into the aorta. How am I in terms of timing?
Anand, you have to tell us.
We were okay to crack on as we are because we were expecting a few less steps, but it became more steps for this case. I was so hoping it will be a provisional. That was my intention. I think 34, we couldn't have afforded to take anything less. I think you are absolutely right, and thank you. Makes a big difference getting all these inputs. Stent boost, cone down. Is he okay? You're yeah, towards the end. So I just want to have some support here. Just show me the ostium, please. Cone down, go LAO. Cranial. Mask off. That's okay. Cranial, check the overlap. Overlap is okay, just about one stent. Try not to talk to the patient, guys. I don't want any deep breaths. Chaps, no talking, no deep breaths. Chaps, no talking, no deep breaths. It's a bit touch and go. Abu, be prepared to go. One second. Okay, we're just going to take the circ wire off. I just want to be prepared. Abu.
Yes, sir. Ready, sir?
Go up, Abu.
Yes, sir.
Quick.
Yes, 2 3 4
Nice. Okay.
10 12 12 nominal
14,
14
16.
16
Just got a little bit of left main left behind, as you can see, but I'm okay with that. What do you think, Dr. BBC? Okay, down. Now, OCT, the left main ostium was normal, sir. But the downside is we have a very short left main anyway. We don't have proper shaft deployment capability. Okay. So here I would normally post dilate also and then recross. That's my usual thing, but let's see where we are now, and then we can decide. As long as this flow, come apicaudal, please. Boys, come apicaudal. 3.5 NC. As long as it's not too bad here, then we're okay. Yeah, we're okay. We'll do a post-dil. 3.5 by 12 NC. So we're going to do a 3.5 NC post-dil to the proximal LAD, and then a 4 to the ostial, i.e. pot of the left main. One could argue that we could minimize these steps, but given the calcium and the bulk that we had there, I'm just taking every step, even if it involves 1 or 2 steps extra. We just don't want any room for error. So it might sound too paranoid, the steps for an experienced operator they watching. ACT?
250.
Okay, give another 3,000 heparin. Peripherally.
Even with such a good IVL preparation and post that a 3 mm NC, still I think the stent is like that. It's expected.
Yeah.
And needs good post dial. At the same time,
Okay,
one
go up.
will be cautious about potential nodule outside the stent, which can increase the chance of coronary rupture.
Yeah. 12. 12 Okay, down. So we're just going up to nominal. I'm not going mad here. I think one of the good things about this stent is the visibility, the fluoroscopic visibility. It makes a big difference. Okay, go. Because every time I'm pulling my balloon back, the guide always gets sucked in. You really don't want to damage the proximal stent in the left main, which essentially is hanging because we have not optimized it. Okay, down. So it's very
Practically speaking, would rotablation along with IVL be more beneficial in these kind of
yeah, absolutely. I think I had that in the back of my mind, but my strategy was to see if I can take a balloon. If I can take a balloon, then I now no longer use rotablation to debulk. I just modify. If I can't take anything, then of course I would rotablate and then do a lithotripsy. Go up.
Or maybe we could have used the OPN balloon after the IVL. That also would have prepared the belt better.
Okay, down. 4 by 6, please. Yes.
A very good point here. And if at all the deep calcium modification you have to do, it's better to do before you go with the stents.
Absolutely.
The moment you put a stent in, you are not dealing with the same artery anymore.
Absolutely.
You are dealing with an artery, the calcific vessel with a stent there. So whatever you try post-stenting high pressures like OPN, the stent will start opening up opposite the calcium side. Upsets can happen. So Heraclitus statement, I always say that. We never enter the same coronary artery again once you put in a stent. It's a different artery.
Yeah. And even for IVL, one of the points I wanted to demonstrate, but I didn't show it, I just went very quickly, was the lithotripsy balloon, as many know, is very bulky. This amount of calcium, once you come back, it's very difficult to go forward. So it's always best to start backward and come distally and come proximally. But here we had a few issues which I didn't show or spend time in detail, because every time I went up with the balloon of the ostial LAD and left main, the pressures goes down significantly. The patient didn't tolerate it. So we had to take the balloon out after 3 cycles and somehow reintroduced. And that, of course, invites more dissections, acute vessel closure and all that. Something to bear in mind just for the viewers. 4 NC. 4 6. 4 by 6 or 4 by 8, whatever. Kodunga. Give me this again. ACT corrected.
3,000 given.
Okay. I want a 3 new balloon. Ready? 312. Cone down, super mag, boys. Thambi, vanga. Super mag, full screen. Bigger. Okay, what do you think there? Dr. Elilan, Dr. YVC.
Bifurcation, I think we have to go a little more. The LED stent at the carina has to expand a little.
This is this is for the pot. We're going to do the pot and then come back.
Pot position, yeah, I think you're fine.
You're happy, yeah. Any you were not sure, Dr. YVC? What do you think?
I think a little bit drag back towards the guide. Yes, this is good.
Better? Okay.
Yeah, yeah.
Okay, go up there. Go up.
6, 8,
8, 10, 12, 14, 16,
16,
18, 20.
26.
Okay, down. I think that position looked good, at least angiographically. So,
This is where, if there was a chance, I would be very happy covering the left main, at least on the inferior rim,
true,
so
true.
that the trauma.
Get the. I need a 3 I need a wire and a new 3 balloon. So we're going to rewire, recross, and then take a 3 balloon, and then
Very little stent in left main for a pot, actually. but
yes.
Yeah. You could always put one short stent if needed in the left main.
We will do an OCT because the left
yeah.
main was short anatomically, which was largely disease free. Okay, cone down, submag.
These are the cases which XB will be tough, but then that is the only guide which will help us do the rest of the case. So I think we should do it with XB with all the precautions. XB or EBU.
3 balloon.
So I thought I was a little bit distal. I'm just going to be I'm going to come back and try for a better position.
Okay. Dr. Anuj, your comments. How do you proceed?
Dr. Anuj Kapadia.
Hi, sir.
Hi. How are you, Anuj?
Good, good.
Please, give your expertise. Let us know if
I think
you're
it's going great. Just that I think we need to.
3-5 and a 3 balloon.
I think there is
I want a
new
3-5 and a
after
3
the
balloon.
lady will talk.
Yes,
If
I'm.
you have more pulses of the OCT of the IVL, would you want to just use the IVL?
No, I'm going to do a post-dill of the ostium now with a 3-5, which is a kiss between a 3-5 in the LAD and a 3 in the circumflex, and then we will relook at it, and if needed, we will take a 3 or a 3-5 IVL, because what we used was a 2-5. That's what we used. So we'll have a look once we finish the final case, because as Dr. YVC also pointed out, after stenting, I've been very unconvinced that it does a great deal of difference.
I think in these type of massive calcific lesions, I think we know we have to accept some
Absolutely.
amount of,
So we're going to rely a lot of imaging. So we will look at the MSA, mean stent area, and if that is satisfactory and there's no big bumps like a nodule, I will accept it, because you want to make sure laminar flow. That's what causes all this instant restenosis. So let us see. But I'm open for another IVL too. But in terms of using remaining pulses, we've exhausted everything of the 2-5. That's the only balloon we use, and all this shying away is pretty much the cost. Let's say it was like an NC balloon. We'll be using left, right, and center. 3-5. 3-5. It's not going in. Let's anchor it in the LM. Okay. Get a 3-5 in the 3-5-12 N balloon. N. And one of the other things is using an N balloon for all the recrosses, because multiple times we have tried to save balloons costs, and we may get lucky, but I think one of the things is we often dig a hole for ourselves by reusing, and does not optimize the procedure well. And reused balloon, especially if it's not profiled well, we actually don't know what kind of damage it could lead as it traverses through unintentional areas.
For anchoring, we have only this.
3-5-12. 3-5-12 to the LED. New.
One of the comments in the chat was whether a 7 French guide would be making our job easier.
Yes,
But again,
yes.
what we are doing in the radial route.
Radial.
This is a very well built man with
Yeah.
a 7F guide and go into a 6F cylinder sheet. We would like to continue the 6F radial.
I think 7 French now with sheetless guides which are available, that might be an option also, but we don't have it in our lab yet. That's a very good suggestion. We start with 7. Bigger the better, absolutely. It's always difficult to change after. The pressures are okay, and from the head end of the patient, he's okay. Dr. Swapna and Dr. Smyrna are happy, so I'm happy.
Anand, we have all the talks remaining or some are dropped?
Yeah, so we have one live in talks which is dropped. Dr. Sathe will not be looking at it.
So the next is that?
Okay. Yeah.
Yeah, so
Go up. 10.
Reddy and Arun Chopra, I am next actually. Dr. Arun Chopra is there.
Okay.
So what I've done there, you can see I've just anchored the LED balloon and managed to squeeze the 3 circumflex balloon down on the anchor.
That's a very nice trick.
Pod balloon ready பண்ணி வைங்க திருப்பி.
4-6.
Okay, ready for a kiss? Ready? Okay. Go up.
Gopal, if you allow us, we'll go for a live inbox.
Yes, yes, 12 both.
We'll come back.
Yeah, sounds good, sounds good, sounds good. Yes, thanks. I'll see you there.
Thank you and keep doing good.
12, 14, 16.
16.
Yeah, we are there at
Gopal, we are here.
Yeah, hi, hi. So let's show the come back. Go to the previous one. Back. So we did the. I think you saw up till the pot. We finished the pot, and then we just wanted to do another 3.5 dilatation also, which we did. Because the proximal left main we thought may not be, proximal LAD, we may have a nodule on the outer curvature. So we thought we'll do a 3.5 NC. Then we did an OCT. Can we show the OCT, please? The last OCT, the one where there were 1 or 2 struts across the circumflex.
3D cutting. 3D.
So this is the OCT run. Come proximally. We don't want the distal. Just let's not waste time. Come proximally. Okay. Can you see here the OCT? So show us the circumflex, please, ostium. So you can see here across the circumflex ostium, LAD, I'm happy. And can you show the area, the proximal LAD, 1 or 2 millimeter into the LAD, please, where we think there was a nodule? No, into the LED. Go into the LED. Go into the LED. We are not quite into the LED. Go into. Okay, great. So here we were happy. The MSA is very good. There was no big under expansion of the stent. There are one or two areas where it's not opposed, but that's okay. It's not too bad. And the stent morphology is pretty circular, where we think angiographically where there may be a problem. I was not convinced there was a problem to need much attention. However, what I did think we needed attention was we were left with a few more struts across the circumflex, which we don't want. You see that there? Can you show the 3D rendering? 3D across circle. Zoom in there. Zoom in there. Okay, you can see those one or two stent struts at the 11 o'clock or 12 o'clock position there across the circumflex, which I didn't like. I wanted to fix that, so I re-entered angio. So next, 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 next. So we did another high pressure balloon again of 3 going up to 20 atmospheres in the circumflex, and a 3-5 again there. That's the final kiss which we just did, and we've just repeated the OCT. Next, angio cutting. The angio looks very pleasing there. It actually looks better from whatever it was before. The outflows were all fine. The inflow of the stent at the left main was also very good, so there's nothing in the very ioto-ostial position that needs addressing. Show us the latest, please. So this is the latest here. Can you see here? That's the guide wire. Zoom in there. Zoom in just the get rid of the angio. Just show us the OCT. That's it. This is after the second case which I did, because I was not happy that we had one or two stent struts across the circumflex ostium. Now you can see en face on the circumflex ostium there is not a single stent strut. This is what I wanted, so that we have absolute precision. That's the whole idea in this patient, where as you can see, multiple steps may have been repeated. There may be an element of paranoia that you might see, but the intention was, at least procedurally, we don't know how he's going to react, but at least procedurally we wanted to make sure absolutely we have spot on bifurcation there. Show us the inflow of the stent, please. Inflow. So there you can see we're just showing the inflow of the stent. Very small area of stent into the left main, but this is the stent inflow. You can see there, well opposed, and the rest of the left main into the aorta is pretty good, and I think we are done here.
Nice final shots and images. Yes, yeah, Helen and Anuj comment.
Absolutely 15.
Well done, Gopalamurugan.
Thank you.
Actually, opening up that 2 struts which are projecting in the circumflex was really helpful.
Yes, I definitely. So we're going to leave him on dual antiplatelet. He's an aspirin ticagrelor. What we did was, as we do for many liver patients, we actually leave them, and majority have one bleed or the other. So we leave them on a trial of 15 days of dual antiplatelet. This is our routine. I leave them all on aspirin and ticagrelor for 15 days before the angioplasty, making sure this therapeutic trial proves that they're not going to bleed imminently, because you don't want to end up with such a situation after the stent. So we prime them for 15 days, and then we embark like in this case. So very pleasing result. Thanks for having us, and we are honored.
Gopal. Excellent.
Thanks.
Very nice case.
Anuj, yeah, and Vimal is there back. Yeah.
Yeah, very nice case, Gopal. Very nicely done.
Thank you, sir. I'm honored.
All meticulously done with excellent
Thanks.
result, and it's impressive to see how meticulous you are. Even a few struts in the ostium of the circumflex, you didn't mind to dilate again. So
Sure.
It's really fantastic result.
One question, Gopal, what do you think, why the struts were there across the circumflex ostium despite the kissing initially? Was it undersizing of the side branch balloon, or what do you think?
I think there was a lag between the release of the circumflex and the LAD balloon kiss, which may have pushed one or two stent struts on towards the circumflex, i.e. the circumflex balloon probably came down early, and the LAD balloon came down late, whereby pushing one or two struts across the circumflex ostium, which is the point of least resistance. That's my postulation, but I may well be wrong.
I think that's a very interesting comment, and in fact, it's for the audience, it's very, very vital that the two indiflators should be in a duet. It should
Absolutely.
be very consonantly done. Otherwise, things can happen like that. And wonderfully recognized. And of course, you are a master. You're looking for precision for the final result because it is a DAP dependency HBR scenario, and you wanted the best optimal result. Excellent, Gopal, and kudos to all
Thanks.
your team. Great.
Thank you.
Thank you.